I'm going to grab this one this time and hope that I've got the right microphone. Hello again, everybody. Lovely to see you again. So as Angelica just said, we're next going to be discussing international cooperation models for workforce mobility. How can countries, big and small, lower middle income, high income, all work together? And as Angelica said as well, we will be taking some Q&A time towards the end of the session, so please do have a think through when you hear my guests. And let me introduce them. So Dr. Kate Tulenko is the founder and board chair for Corvus Health. Rachel Dessem is the steering committee member with Frontline Health Workers Coalition and also a global strategist for health systems and workforce with the World Bank. Anne McKenna is the director of partnerships with the University of Global Health Equity. And last but by no means least, Felicitas Riedel is the director for innovation and competitiveness with the European Investment Bank. There should be enough chairs. Yes, there are indeed. It doesn't matter. Lovely. And microphones all on the seats, lovely. So I want to start, Anne, if I can come to you. Can you give us some ideas of some success stories? Let's start on a positive note. Some success stories so far in both health workforce retention, but also mobility as well.
Thank you so much, Hannah. It's a delight to be here. Thanks for having us. I'm going to twist it a little bit and give a bit of a context so the success is meaningful. And the context that we operate in is in Africa. As many of you know, we've got 25% of the disease burden, but only 4% of healthcare workforce that's addressing this. It's been shown that the healthcare workforce migration costs about $2 billion for some countries, $2 billion US dollars. And this is projected to go as high as 1.4 trillion by the time we achieve the Agenda 2063. And so we are operating from a really strong deficit. And the question for us is, how do we address this sustainably, equitably, and with dignity? And the Partners in Health frameworks help us to do this. And I work for an incredible institution, the University of Global Health Equity, that is seeking to address this both from the root causes, but also for the long-term sustainability of the healthcare workforce in the continent. The two things that I think is worth mentioning is that the privilege that we've got as a university with a global partnership focus is that we get to work with students who sit in the corridors of the patients that they're going to be treating. They sit on the dirt floors and work with the individuals that are actually going to be coming through their doors. So they deeply understand the context because, as we say, healthcare is a contact sport, right? But at the same time, because of our partnerships with Harvard, Yale, Stanford, Oxford, and many other global partners, we get them to see, to access world-class education. They're able to access world-class simulation labs and be able to learn and get an education that can be translated anywhere in the world. And I think that's the most positive and the most unique positioning you can have as a medical school in the continent.
Thank you, and we're going to come on to talking in a lot of detail, I'm sure, about how how healthcare professionals advocate for themselves, and also talking about education as well. But Kate, let me come to you next, because on the issue of international collaboration, how do both host countries and countries of origin all work together then in order to ensure that they're strengthening and not draining their existing system?
Thank you so much. So if health worker recruitment is done properly, it doesn't have to be a zero-sum game. It can be win-win. And that's the type of systems that we develop. So we saw that when someone would recruit a health worker from Nigeria, from India, a community would be deprived of the health worker. But we realized, what if we engage with the schools? What if we expand them and we recruit the health workers through their alma maters, where there's that platform of trust, because that's where the most trust is. And also by engaging with the school, we know the quality of the health worker. And so that way, when you recruit a nurse or other health worker through our platform, we train to replace them. So it actually strengthens the original health system. And there are other wonderful models of international cooperation. Ireland hires GPs from low and middle income countries, trains them to be surgeons in Ireland, so Ireland gets the benefit of their labor during that time, and then they're required to leave Ireland. Many of them go home, many of them go to third countries, but it's a win-win situation because they're not taking specialists, they're actually creating specialists.
And tell me a bit more about this Irish island system as well. Is it a one-off, or is it something that's a blueprint that others can copy?
By the ministry. And so they're committed to deploying their best and the brightest ideas to solving the most critical challenges wherever they are sent to. And finally, to retain them by creating an ample environment, a conducive environment, the spaces and the equipment that they need to flourish as individuals, but also as our doctors.
Thank you very much indeed. Kate, before this panel started, then we discussed the fact, or you'd mentioned that this conversation about a global health workforce has been going on for 50 years or something like that. I suppose the biggest difference today that I could see is AI and digital platforms, and that opportunity within education as well, digital learning platforms as well. I know that you've got a lot of experience with this through Appleseed Education as well. Tell us a little bit about how we can leverage these digital learning platforms to improve the experience of workers themselves, but also the health workforce globally and mobility within that.
Thank you. So we all know there's an 18 million health worker shortage. In many ways, this is going to increase with the aging of the global north. They're going to need many more workers, especially elder care workers. So it is essential that we expand health education programs, particularly in the global south, where all the young people will be, where all the workers will be. And right now, the model for expanding schools is sort of onesies and twosies. When I was the director of the U.S. government's Global Health Workforce Program, we would work with individual schools. But now we're in a phase where we need systems, we need platforms that raise all boats. And we founded Appleseed Education to be that EdTech platform to expand, digitalize, and improve health professional schools in low and middle income countries. For each school, we help them do an assessment, set goals, and then provide the technical assistance, the group procurement, to help them reach those goals. So it's much more cost effective than flying people in or out, or that sort of the old model of technical assistance. And from an AI point of view, we partner with a learning platform such as Lecturio, the CEO for that will be here on Wednesday, which use AI-enhanced education so that learners can learn faster, deeper, and with greater satisfaction. And a very important thing we need to discuss over the next 3 days is regulators need to approve the use of digital learning. A lot of regulators are very conservative, very rigid, and will not allow digital learning. Another thing that we need to discuss, and we're going to talk a lot about curriculum, and the standardization of curriculum and competencies is essential for global mobility. But health professional schools are complex organizations. It goes beyond curriculum. We recognize 20 different functions of schools, from admissions to tuition to procurement to transportation to clinical practica, and they need skilled management across all those areas, and that's what Appleseed Education supports them to do.
Thank you. Yeah, go ahead, Anne.
Yeah, so I was just going to piggyback on that, actually. And one of the things we're learning now is that it's not enough to train the medical doctors and the healthcare professionals. We've developed a program called HPE, Health Professionals Education, which is training the educators, because being a good doctor, no offense, doesn't make you a good teacher of doctors, right? So with HPE as a model, we are training the trainers, as it were. We're training the people educating the medical workforce. And so we can scale how quickly we can teach medical professionals across the board much quicker. And at the moment, UGHE is a secretariat of a consortium, the first ever consortium of medical schools across Africa, 115 medical schools coming together to say, how do we harmonize our curricula? How do we make sure we are keeping up to standards across the world of the way we train? And we've just adopted an UGHE.ai model that is going to take the education that we offer our scholars and scale it across the continent. And I think it's really powerful what you say is that we need to think about the regulation around digital education. It's not a thing of the future, it's here and now. And how we leverage these platforms, these emerging technologies, to really both scale, standardize, but more importantly, personalize a medical education is going to be one of the most transformative things that we do for the healthcare workforce of the future.
And thinking about these digital platforms and the new technologies that are coming in, Fili, if I can ask you about the role then that institutions like the European Investment Bank would play in educating people about what is possible, what's available, what financing models are available, but also you're talking about regulators, Kate, and the fact that people are just they're scared. People don't really understand AI or don't really know what the benefit is. All we hear about at the moment is just that this is scary rather than this is progress. So what role can you play from the kind of like the finance side in encouraging people to take that big leap forward?
If I may allow to just make some additional comments
Of course.
from what we perceive through our work. So first of all, I fully support that AI can be a game changer. AI really offers an opportunity to allow for different curricula. As I said before, or I was alluding to, where you basically do the practical training locally, but the theoretical content can be provided in a more centralized manner. Accreditation plays a major role. But I see here also movement from regulators that there are now, thanks to AI, you can now really ensure that it's the person in front of you with recognizing the eyes, seeing where the eye is movement, if they are trying to cheat. So I think the possibilities are actually there to ensure it's this person actually sitting the exam and not somebody else, even though it's done, or the conduction of this class is done in a theoretical manner and not physically present. And another aspect I wanted to say is that it's also something we do support. AI also offers a different innovation pattern. What we see now is that thanks to AI, we see innovation driving from middle-income countries. Because if you consider now, for certain cancers, you do a swab, and then in the past, there was done just a picture in a microscope. Whereas you have in high-income countries these sophisticated clean room labs that were doing and running these type of tests. Now with AI assessing the pictures, actually there has been an algorithm that is more accurate than those done in these centralized high-income labs. The point I'm trying to make is that this is really offering as well for different types of settings innovation. How it comes to financing, to get back to the original question. Here again, what we do offer as EIB also financing of students' loans, of education, as we believe, again, you need to support the public and the private sector in order to make it work. It is important that primary healthcare, for example, is really embedded in national strategies. And here again, a point I think that you were also alluding to. We need to make sure that those workforce that we do educate are able to also work in sufficient facilities, and that it's heartbreaking if you, for instance, start to finance doing diagnostic tests, but then you may know that a person has a certain disease and you have 0 treatment options. So even if maybe this doctor or a nurse would like to stay in this setting, it's very hard mentally. So therefore, it might not be just the fact that it's money-driven, salary-driven, but it's also to be able to do the job in a professional manner. And hence, being a policy bank, we not only bring the funding, but also embed it in a sustainable way. Just to give a figure, at EIB, we do between 3 and 5 billion euros a year in the healthcare sector, and I think in 2024 we have approved access to healthcare for over 7 million people, so it still has quite some significant impact that you can do also being a bank in this sector.
And Rachel, you wanted to add to that?
Sure. I think we've been focusing on AI at the graduate student sort of level, but to bring it up to systems. So we're all here because health workers count, right? We know they count. And we know that if we need to invest in them, that they're not a cost, that there's a value, 10-to-1 return generally on investment in health workers. But if you were to ask a minister of education or a university planner or a policymaker at the Ministry of Health, how many health workers are you training? How many do you have? Where are they? Are they supported? Are they salaried? Are they supplied? Do they have the space that they need? It can be very challenging to have that answer. And the most glamorous thing of all that I would love for you to keep with you is these human resource information systems that health workers count, and we need to count them. And we need to have the global picture. We can't talk about the bathtub if we don't really, have any sense of the faucet and the drain. And the WHO has done a lot of work with national health workforce accounts to establish data standards and data governance standards. I worked on a USAID-funded project in Burundi and had access and was working with the HRH directorate there. And it was a big, long, messy, beautiful Excel spreadsheet where infirmier and infirmière maybe had the accent, maybe didn't. It took ages just to clean that. And that was years ago before AI was ready. I see opportunities to digitize a lot of paper-based HR systems that ministries of health and universities are struggling with so that you can know, you can hold accountable partnerships for how many people have, health workers have been trained, where have they moved to, what are the trends, what are the dynamics, what are, the accountability mechanisms for their safety and protections. I mean, there's so much that you could do. And that includes community health workers and looking at the ways that they can be integrated, particularly where they're providing so much for primary care, the potential that they have as they grow towards addressing NCDs. I was the Global Technical Director for the Chemonics-led HRH 2030 program. And in Indonesia, where there is a very sophisticated and mature digital infrastructure, we were able to, through data standards and support to their various departments within the ministry, really build a bridge across the training, the qualification, the national and subnational sorts of human resource information systems. There were many divergent systems. There were like 17. And they were pulled together so that then when COVID came along, they were able to look at surge capacity and epidemic data, epidemiological data, and then understand who their health workers were, who they could send over to the surge capacity, hospitals where they were needed most, and also know that primary care would still be continued in the places where they were, moving around to. So there are so many opportunities. Health workers count. Invest in basic data systems, and then with quality data, AI can do so much in terms of what trends, what dynamics, how health workers are succeeding, and make the case for that return on investment.
I wanted to build upon what Rachel was saying about accurate data. I oversaw a project that was able to eliminate over 6 million ghost workers in the Dominican Republic. These are fake workers. It's massive level payroll fraud. People getting paid twice, people who are retired, who are still being paid, fake people. But by having the correct data and seeing who's on the payroll, who actually shows up at the hospital, you're able to clean these payrolls. And in the Dominican Republic, they were able to free up about $9 million per year that they then used to hire real health workers and pay all the health workers more. So really, pretty much every low and middle income country in the next year could unlock millions of dollars through doing that, because the WHO estimates that about 20% of most health workers on the ministry payrolls are ghost workers. So this is a very important thing that countries can do to free financing, and also it helps with the morale of the existing health workers. If you're the one nurse who actually shows up at the clinic when you know there have been 5 nurses assigned, it's extremely demoralizing.
Thank you very much. I had no idea about the scale of the ghost worker problem across the globe. And on that issue of building trust, because that feeds mistrust and distrust across the board, right? When there's lots of fake workers out there. And if I can ask you about this, you have to build trust for everyone collaborating in this. Everyone in the conversation, both from the top down as well. So when you're looking at Africa-led initiatives, how do you kind of ensure that trust is really there? So it's not just the higher income countries who are just talking amongst themselves, but it's actually, everyone has a seat at the table when it comes to making progress.
That's a really powerful question. And I think the first thing that we have to recognize is a values-aligned system, right? Starting with what's our shared value here, what's our shared agenda here. And for us at PIH, at UGHE as well, there's a very fundamental belief that we believe that every person, wherever they are, deserves and has a right to good health. It's a very simple concept, but you would be surprised. And I remember going into the university the first time, and I saw this quote from Paul Farmer, who started the university, and was a co-founder of PIH, and it was, the root of everything that's evil in the world is believing that some lives are worth more than others. I am severely paraphrasing it, but that's the essence of it. And if we can start from a shared understanding and a shared value that every life counts, and that where you're born, where you're raised, raised should not matter in terms of whether you can get access to healthcare, I think we've started on a good front. That's the first base. The second base, if we understand the why we are doing this, the how becomes a lot much easier, much, much easier. But if the why is aligned, that's usually where we have a bit of a grit. The how we get there is also a question of understanding an asset-based approach, right? You've got this, I've got this. I can benefit from you in this way, you can benefit from me in this way. At the university, we have over 100 faculty coming from global universities that come to teach on our courses. As I said, the students get the real and sitting down in these homes, and they get the ideal in working with global workforce, right? The global leaders, the people who wrote the books, right? And these people understand that when they come to our university, they're not coming for charity. They're not coming to give. They know that they're coming to take. You're learning a different way of doing business, a different way of healthcare, a more holistic way of looking at a person before they're a patient. And that is a different way of delivering healthcare, not sick care, right? You learn that from our community health workers. We say those frameworks are great, they don't apply here. You learn a lot from the students who challenge the premises we've had in the healthcare sector for many, many years. So understanding that there's a mutual benefit to be had, that you learn from me, I learn from you, you gain from me, I gain from you, is how we develop the systems, the hows. And then finally is having a similar, not necessarily a similar, having a shared understanding of what impact looks like. What does success look like? For us, we're fortunate that we work with a government that understands, has the data to back up what their strategy for healthcare workforce is. We work around the 4x4 strategy by the Ministry of Health in Rwanda. They want to quadruple the number of healthcare workforce they have in their country, because they understand the shortages, and the number is actually, I think, 32,000 or thereabouts for the numbers of individuals that they want to train. And so we have a clear success metric. What's your success metric? Let's be honest about that. What do you want to get out of this? At the end of the day, what's the bottom line? What's the gain that you're looking to get? And if we have a shared understanding of the why, the value we are holding together, the how we get there, and the impact that we want to make, the success that we want to make collectively, then you can build trust.
I think that's such an important point, that we're talking about international collaboration, right? And you need to first work out what the shared values are. And there are many of them as well. So it's not that there are many, many obstacles and many barriers along the way, but if you start from that fundamental point that we are all in this together and we all want a way out of it that benefits everyone, then that's a good place to start. I promised that I would put questions out to the floor as well, so now it seems like a good time. If there are any questions, thank you, please raise your hand, and then I'm hoping someone will come to you with a microphone. So yes, 2-3 rows back here, please. If you wouldn't mind just stating your name and organization as well, please. Thank you.
It's on. Hello. Hi, my name is Ashvina. I am an adaptive leadership consultant, so I work with healthcare professionals to basically be resilient when things go wrong and in high-stress environment. And almost, I think every week I must be talking to a doctor or a surgeon in a poor resource country setting who's kind of looking at the drain already, at the edge of it, and about to jump, and thinking that they can't deal with it anymore because it's not just lack of constraints, it's also them feeling burnt out from constantly having to fight the system. So we've been talking about trust a lot. We've been talking about, even throughout the weekend, about egos and fear and uncertainty, and rethinking the training of medical doctors, practitioners, healthcare providers, nurses, all these people who are key to the system. I'm wondering, are you rethinking, or have you already started this work of how do we prepare our healthcare professional? And I hear what you're saying, Ms. McKenna, that they learn it as they go. But if healthcare is a contact sport, and we throw them on the rugby field, and that's when they're learning what the value of trust is and how to protect themselves and their teams, isn't there value to do that before they actually get into the system? And how do we do it? How do we rethink it and be innovative in that way?
Thank you for your question. Kate?
Yeah, thank you for that question. And this can be addressed on a number of different levels. During COVID, for Abu Dhabi, we developed a resilience, health worker resilience plan. And it occurs both at the individual, the team, and the systems level. So for the individual, you have to give them skills such as meditation or yoga and things like that, and access to mental health services. At the team level, you often have to do complete redesigns of teams and roles so that jobs are more humane, that jobs are easier. And at the systems level, you have to think we need duplications. If some health workers are out, how can we make up? And so you have to do it at all three levels, the individual, the team, and the systems. And then back to training. So I have to say, I enjoyed medical school, had a lot of fun. Residency was a different matter. Residency made me a worse person. If you do something to me, that would be a violation of the Geneva Accord, or you do something to me that would be a violation to do to prisoners, you probably should not do it to a health worker in training. I'm getting all emotional just thinking about this. Yeah. How can you expect people to be compassionate when we are not treated compassionately in our training? We're saddled with all the debt. We work terrible hours. You have to treat health workers humanely at every single step. And the burnout, as Dr. Jonathan Shea defined as a moral injury, people wanting to be good, working in a bad system. During COVID, we saw health workers dying while managers making 3 times as much were working from home. It was not fair, it was not just. And we need these complete system changes. And I think a lot of jobs and teams in healthcare need to be reworked and rearranged. And this is a much longer conversation, but thank you so much for bringing it up.
Yeah, Rachel, yeah.
Yeah, quickly. I think burnout is real, and no one should have to, in the words of Geraldine Hoover, who I think is speaking later, function heroically, constantly. And some of that is because of health worker shortages, because of challenging situations. In Malawi, the HRH 2030 project developed a chat bot. We worked with Vitalk, this really cool Brazilian tech firm, and it would, as on a mobile phone, help to screen health workers for levels of burnout, stress, anxiety, and depression. And I think it was something like 80% had some level of something. And then that was an opportunity with that information for the health system to then identify and plan for ways that they could address these sorts of challenges. When you talk about the issue of being at the drain, something needs to change. We need to treat health workers with dignity.
Thank you.
So can I,
oh, yes, of course, Anya, go.
I was going to, thank you for voicing that. I was going to share a personal experience, actually, because I've worked in both extremes, if you will call it that. When I worked in a certain healthcare setting in Kenya, after I did my training, and I remember feeling very powerless to do anything about the things that I was seeing, and that was a moral injury. And then I went to the other extreme where there was lots of excesses, and people demanding things that did not serve them and ending up with overcare. And that was a moral injury for me as well, on the other side of that drain, thinking, how could we possibly allow this person to pay this much for something that could have been solved by a 17th of the cost, right? And either way, there's a moral injury. So this is not just a lower middle income problem for healthcare workforce, it cuts across. And as we talk about dignity and so forth, let's also think about the systems that underlie these challenges that we face and how we can be participants in shifting those systems. One really critical thing is thinking about, I talked to one of our students when she was graduating, and she was given a chance to work in a global institution and got another job in Rwanda, and she chose to stay in Rwanda. And I asked her, why did you make that decision? Most people who are there circling the drain would jump off. And she said, because here my life counts for something. And that's all I needed to hear.
Thank you. Yes, just a second row here on the side, if the microphone could go, please.
Good afternoon. I am Marian Suba from Liberia with the Sustainable Community Action for Peace and Health. Thank you all very much. I think that For a person who's been in education and training for especially the past 15 years, we heard a lot. But there were two things that I would like for you to please emphasize a little bit, especially when you talk about the space and all of that. For now that we're doing pre-service education, especially where you talk about looking at the different professors from all of the other places, how do we get that clinical matching, the theory? Because like in the hospital here, I work at Johns Hopkins Hospital, and the hospital, I'm going to Phoebe Hospital in Liberia. The clinical is like completely different, even though we may have the same books. So how do you get that clinical to get there with that international standard? And then my question number 2, thank you very much for emphasizing the whole thing about the health workers, professional educators, not because you are a wonderful nurse, meaning that you are a wonderful teacher of nurses. One of the things that I have found out is this whole thing about leadership, and I wanted to find out if you had programs for that, because like people graduate from nursing school, and then you become the head of the nursing college, or you graduate from medical school and you become the minister, So how do we get that leadership? Because I have found that leadership thing, the results really depend upon leadership. Thank you all very much. It was excellent.
Thank you very much for your question. Kate?
Oh, sure. So on the issue of the clinical experience, if I understand what you were saying correctly, we can all learn from the same book. We can all learn digitally the same thing, but what a nurse does in Liberia is very different from what a nurse does in Manhattan. And so what to do if that nurse from Liberia moves to Manhattan? They need what we're calling onboarding education, because when I as a physician go into a hospital in low and middle income countries, I don't recognize half the things because it's different. The drugs are different, the infusion systems are different, and so you need that onboard training. That is essential. And then and then you need good bedside teaching, and that's, I think, what you're doing there. So if you're a nurse dealing with a student nurse, you need to know how to teach her, usually on a case-based, patient-based. This is what we did to the patient. This is why we did it. Do you have any questions? What was difficult for you? And people have to be taught how to be good bedside teachers. And then on the leadership, many more schools are integrating leadership into pre-service education. So every physician should have some leadership training. Every nurse should have some leadership training. But when people get into those high levels, like deans or assistant deans, they need extra training. In the U.S., the American Association of Medical Colleges has what they call Dean School. So every year, all the new deans of American schools of public health come together and they get trained. And we do the same thing on Appleseed. So if there are any new deans in our membership schools, they get that extra leadership training.
Thank you so much for raising that. And we do the onboarding the reverse way as well. So when we have professors from Harvard coming, we do capacity building. Who would have thought? Because there is lots that needs to be learned. And I think it's better to step back a little bit. As a medical practitioner, your greatest teacher is your patient, right? And that understanding and coming with empathy, first of all, knowing that whatever you've learned, whatever the context you're coming from and all of that, what matters most is the person that's sitting in front of you and how you're going to interact with them, the bedside manners you're talking about, how they see you interacting with your residents and so forth. That first level of understanding that all your fancy gear and all of that is not worth anything if you don't make the life of this individual better. And I think that's universal, but I hear you completely, and we have a very robust way of training our faculty who come from abroad to understand the context. And we don't just take anybody. There's a process of evaluation before you come in to make sure that the values are aligned, to make sure that you understand the context that you're going to be operating in and so forth. And in addition to doing our MBBS training, we have a very robust Masters in Global global health delivery, which, as I said, the Minister of Health is an alumnus of this program. And so for us, the health delivery is a whole other thing. It's not just learning how to do the basics, it's understanding how you integrate with the healthcare system, how you lead from a place of empathy, and so forth. And this is integrated in our MBBS training. So after you finish your 6 years, you get an additional year of training to do the Masters in Global Health Delivery. It includes leadership. And one thing that we need to talk about, I hope in the next 3 days, is hospital management. We're starting a master's program, a postgraduate program on this. But one of the biggest challenges when we talk about healthcare workforce, we talk about nurses and doctors, but then there's IT specialists, right? There is HR in the hospital. There is procurement in the hospital. There's a massive enterprise. And providing training programs for people who work in these spaces, just because you are great at IT in a bank doesn't mean it will just seamlessly,